The information in this podcast is provided for education and research information only. It is not a substitute for professional health advice.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And we've got one of our favourite podcast types today.
Q&A.
And I think they're back. And I actually think it's everybody else's favourite as well.
They are. The feedback from Q&As, we get more feedback and people are quite excited by it. It's good.
And I hope that, obviously we can't give individual medical advice. That's not what this podcast is about. But we choose ones that we hope have general enough application that our listeners get a lot from them.
Yeah. And occasionally it gives us ideas for whole podcasts.
Oh, yeah, lots actually. So if your Q&A hasn't been put into one of these episodes, don't despair. We may have used it for an actual podcast episode.
Terrific.
Great. All right. So you just want to get straight into it. No chit-chat today. All right, here we go.
Hi, Dr. Pat. Hi, Bridget. Thank you for such an amazing podcast. I am hoping to try and get pregnant in the beginning of next year, so have been listening to get my mind into all things baby and all things pregnancy. I have 2 questions relating to my previous labour. My little boy is now 2. When he was born, I'd had a very, very long traumatic labour. I was in labour for about 4 days. My contractions, about maybe 75-80% of my contractions were extremely long. They weren't the normal sort of 90 seconds. They were about 5 to 7 minutes long each time. They said that they thought this was because of maybe his position in that he was leaning more on one side of my cervix. So my question is maybe that's something that could happen again, because they were very, very long contractions and very hard to cope with. So obviously that makes me anxious to have another pregnancy and another labour. The second part of my question is just after my little boy was born, the consultant tells me that the cord actually tore. He was born by forceps, and she tells me that the cord ripped in 2. She was able to deliver the placenta. It was fine. But my concern is, could I be susceptible to this again? Is there possibly an issue with the cord development? I'd be really interested to know so that I can plan a future labour accordingly. Thank you again for your amazing podcast.
So we put this in because I wanted to ask you about long labours. 4 days. It's a long labour, isn't it?
It is a long labour, and I don't want to comment so much specifically on the cases on that particular case because we don't know the details. It does raise a question though about sometimes there's a difference between what the woman who's had the birth considers to be her whole labour and what the carers might have considered to have been the active part of the labour. And it might sound like that it's not an important difference, but it kind of is an important difference. It's very common for people to say that the labour started when they first started to get pain. And common sense will tell you that, right? I've got pain, I'm in labour. But the obstetric or medical definition is a little different. And that in that we sort of start the clock when regular painful contractions have started to cause the cervix to open. And that distinction explains some of these unusual stories where someone says, I was in labour for days, whereas obstetric carer listening to that story would go, well, hang on a minute, if you were in labour for days, you would have had some intervention. Mm. Yeah. And sometimes it just comes down to we're not comparing apples with apples about what we mean by labour.
And people will hear that in terms of stages, won't they? That'll be first and second stage, active labour. Can you we outline all of this in our program. I keep talking about our program, and more people on that would know the answer to that question.
Sure.
But what does it actually mean?
Well, for example, it's possible to have a situation like this woman who sent us her story where she had pain, bad pain, that went for 4 days. But that's not necessarily abnormal. And we would often call that situation persistent spurious labour. And sometimes we would sit down with that patient and say, look, you've got a lot of pain here, but we keep examining you and the cervix is still closed. So from our point of view, from our sort of strict medical definition of labour, you're not in labour yet, but we get you've got a lot of pain. And we'll sometimes say to that patient, you sure you don't want us to break your waters and get on with it? But for example, let's say somebody was in good labour. They'd already got to 3 or 4 centimetres. I'd like to think nobody in the world is going 3 or 4 days from that point. Yeah. So we know that good labours are progressive labours, and labours that take way too long have poor outcomes.
And would that lead into her next question, which is the cord ripped in two? Like, is there any connection between the long labour and the cord ripping?
Probably not. In my experience, if a cord breaks, it's often that the babies come out, and then we've clamped and cut the cord, and then we are putting traction on the placenta to help the placenta get delivered. And sometimes if you put too much traction on, or the placenta is a bit more grippy than you think and it doesn't want to come out, then the traction will cause the cord to break. That's an inconvenient situation, but not necessarily a dangerous situation because the cord's already been clamped and cut and the baby's already having a cuddle with mum. So we don't know exactly what happened, but does it represent an underlying problem with the structure of the cord? Probably not. Yeah.
Right.
So the nub of the question really was how should we do this again?
And I know where you're going. You're going to start talking about second labours and second births. We've got a question coming up about second labours.
Good.
So, listener, keep listening because we're going to cover that.
So they go better.
Yeah.
I'll cut to the chase. They go better. But there's enough in that story of your first birth to ramp up a little the expertise and advice you're getting regarding your second baby. So, for example, it would be well worth discussing every aspect of your first birth with an experienced obstetric provider to say, a caregiver, to say, exactly what happened, exactly what was the significance of what happened, and how predictive is that of a problem next time. And sometimes people's first birth is so complicated and so traumatic that they said, "Oh, do that again," and we make plans to have subsequent babies by cesarean section, and that's fine and doable. And other times the problems with that first birth are largely confined to the first labour, unlikely to happen again. And the compromise might be, yes, I am prepared to rock up for another vaginal birth, but we'll do it in a hospital under some expert surveillance. And if it goes as well as I hope it does this time, fantastic. And if it doesn't, there'll be people there to help me.
Yeah. And we just recently did a 2-part story with Kareen, who had a very long first labour and quite a healing second labour. So that'll be an interesting story for you to listen to as well.
Perfect.
Let's move on to our next caller.
Hi, Dr. Pat and Brigid. Thank you so much for your podcast. I certainly listened to it throughout my first pregnancy, and I'm currently 7 weeks pregnant with my second baby and listening to everything all over again. My question comes just in regards to carrying my firstborn baby. He's currently 10 months old and is 11 kilos, going into a size 2 already, so quite a big baby and always has been in the 98th centile. At what point should I stop lifting him and being a little bit more conscious of my own body, not lifting things too heavy? Obviously, he's not quite walking yet, so it is getting a little bit difficult to not pick up and cuddle my baby, but just wanted to make sure that I was doing everything right by my own body and by our new little baby growing inside me. Any tips and tricks would certainly help. Thanks so much.
That's about the same gap as our 3rd and 4th baby, Pat.
Yeah.
And it's tricky.
What did you
do? What did I do? I saw our physiotherapist.
Yeah, that's sort of my answer. There's a disconnect between the advice we give the mothers of little babies and the realities of their everyday life. So if we say don't lift things that are too heavy,
just doesn't work.
you don't have like an assistant coming, walking around with you to do, so the day-to-day life for a mother with a child under 18 months is super busy, and that person needs tons of assistance, and there's nobody to do it but you most of the time. So we have to be realistic. And whilst it's good to avoid lots of heavy lifting particularly in the second half of the pregnancy, as your centre of gravity's changed, your joints can be soft from pregnancy hormones, and your you might be prone to musculoskeletal injury, lower back strain, that sort of thing. Then where possible, it's nice to avoid significant heavy lifting, but that has to be balanced with your everyday life.
It's very hard if your toddler is, not even a toddler at this stage, 10 months.
Yeah, wants to be
held because they're upset. Yeah. So I'm going to say again, in our Grow My Baby program, we've actually done a series with Belinda, our women's health physiotherapist, and she gives tricks and tips.
Yeah.
So it's, making sure that you're still in alignment when you're standing. So you don't sort of sit with that baby on your hip and jut your hip out. So it's sort of either that you're trying to keep your spine very aligned with your pelvis, or you cuddle that child on the front instead of, throwing them on the hip as we do.
Yeah.
And then other little tricks is sort of where you sit down and get your baby or your child to come and crawl up onto your lap. So you're not bending down to pick them up. Things like that. There's modifications that you just have to think about. Well, how can I not stress my body in this situation and still give the comfort or the love that my little 10-month-old needs? Yeah,
perfectly. Perfect. I think some of the I think in a perfect world, maybe everyone could go and see a pelvic floor physiotherapist a pregnancy physiotherapist and hear this advice firsthand. But that's why we included some of those videos that Belinda generously provided for our program, because not everyone can do that.
No.
Yeah.
And, she teaches you how to engage your pelvic floor. It's so important. If you know that you're about to lift him up and he's 11 kilos, what a chunky monkey, that you need to engage your pelvic floor before you actually lift him up at all.
Yep. So switch on pelvic floor first and then load up the strain second.
Yeah. Good luck with your pregnancy. Let's move on to another caller.
Hi, Brigid and Dr. Pat. Firstly, I just wanted to say thanks for such a brilliant podcast. It's really wonderful to have such a warm, caring, non-judgmental source of pregnancy advice, and especially from an Australian context. And thanks specifically for your podcast on induction. It was really helpful to me. With my first baby, I went to 41 weeks and he never engaged. So even though I wanted a vaginal birth and was willing to have an induction, the obstetrician said that we couldn't. From memory, they said this was because his head could have compressed the umbilical cord against the pelvic rim if we were to break my waters, and it could create a vacuum of pulling the umbilical cord before his head, in front of his head. And besides, my cervix was completely shut anyway, despite 2 lots of prostaglandin gel that they gave when his head sort of engaged. So anyway, I ended up having a cesarean. And in the end, he was quite large. He was 4.5 kilos and with a head circumference on the 98th percentile. And so my question is, what are the reasons why someone wouldn't be able to be induced? And also, what are some of the reasons that a baby would not engage their head in the pelvis? Does this always mean that they're very large? I'm struggling to understand why the baby isn't always engaged while their head is small and then unengaged when they grow too big. But they seem to engage just towards the very end. Thanks so much.
What a great question.
It's a cracking question. Fantastic, because that's got tons of stuff in it.
Tons of stuff.
Yeah. Okay, so...
where to start?
Where to start? Management of the high-headed term.
Mm-hmm.
So occasionally we're in this situation where it's term or even well past the due date, and we get to a point where the baby, we know the baby is better off out than in, and the risks of continuing the pregnancy may exceed the risks of induction. So we think, okay, as a team, let's try and induce. The problem is that if the head is very high, what we call floating around, so if you do that little maneuver where you pinch the head in an abdominal examination that you can move the head very easily, whereas it should be sort of stuck down in the pelvis. There's a risk in breaking the waters on that woman, and that is that there's so much room between the head and the cervix that the cord can flop down there, and then the cord can fall out the vagina in front of the head. It's called a cord prolapse, and it's a bit serious and a bit dramatic and need a
There's lots of calls that happen, like, the Met call and everything, don't they?
Quick whiz round for an urgent section. The cord doesn't like falling down the vagina. So sometimes if the head is so high, then we might advise not even trying and saying, look, the risk of causing a cord prolapse here is high, and you might be better off just having a section. And that the pros and cons of both approaches can be discussed with the patient, a plan made. Sounds like in this woman's case that they were trying to induce, and they gave the prostin, hoping that they'd buy some more time and get the cervix nice and soft. And what I guess happened is that they gave the prostin and the cervix did start to soften, but the head was still way too high. So the problem of a potential cord prolapse still hadn't been addressed. And ultimately, they decided that the best advice was a section instead.
And then I just want to talk about terminology, because she said, why didn't they induce? But they sort of did, didn't they?
Yes.
They started the process.
Yeah, they started it. And sometimes just buying a bit of extra time and softening up the cervix, you might get a pleasant surprise. You might come in the morning and find not only is the cervix soft and a little bit dilated after giving the prostaglandin jelly and suitable to have the waters broken, but also the head has come down. And suddenly the concerns about cord prolapse can be put to one side, break the waters and go for it. And that would have been an ideal outcome in this case because we know she preferred to have a vaginal birth. But that's not what happened. And the advice that she was given to have a section instead sounds reasonable. I think so I think, to be fair, they did try an induction. They just couldn't take it as far as breaking the waters. The explanation in this case seemed to be quite a big baby with a big head circumference, and there just wasn't room down in the pelvis for this head. And so there are kind of three scenarios. There's head too big, pelvis too narrow, and unexplained. And I guess there's a fourth, come to think of it, which is that there's something else down in the lower segment of the uterus that's blocking the head coming down. The placenta, so previous, or a fibroid.
Yeah, right.
Other common things. And so, we might have a woman with a large lower segment fibroid who's pregnant and everything's going fine. It's just the head can't get past the fibroid and down into the lower segment. So in those scenarios, if it's not something that can be corrected, then it needs then birth by cesarean section is appropriate.
Yeah, it is tricky though. Like, if this is how I felt. Like I really wanted a vaginal birth. Ended up with a baby with a 98th centile sized head as well. Yeah. He just didn't fit.
No, that's right.
Pelvis,
and if they don't fit, they don't fit. That's that. There's not much that could be done about that. One thing that we do try and concentrate on is, and somehow the discussions I try and have with people in these difficult situations, I say, look, what we should probably do is the smartest thing for this baby right now. And then perhaps we'll have a look next time. You might have a baby that's smaller. You might have a baby with a smaller head. Narrow pelvis, nothing much we can do about that. It's going to be the same pelvis next time. If there's a fibroid, we might look at treating the fibroid between the two pregnancies. And if it's a placenta previa, that probably won't happen next time. So sometimes shifting the focus a little onto sort of saying, well, let's do the smartest thing for this pregnancy, even if it's not what we planned and not what we set out to do. Bearing in mind that we might wind up in a much better situation next time. And if you've only had one previous Caesar, then having that next baby vaginally may well be possible.
And is there another feather in your cap, and that is that perhaps induction could start earlier? Like, she went to 41 weeks.
So that is something that could be discussed in the subsequent pregnancy. The problem is that there are two problems with that. One is that induction carries its own risks. In particular, induction for someone with a previous cesarean section. It can be difficult to get that labour up and going. And So the ideal scenario for someone labouring with a previous section is to come into spontaneous labour at term or near term. And there's also some issues with the accuracy of term growth scans. So we have to be quite confident, if we're hoping for a better result, that the next baby really is smaller.
Yeah.
So some serial growth scans in the third trimester can be very helpful, ideally done by the same scanning service and ideally done by the same person. So we can be as accurate as we can be that this baby's actually is smaller.
Yeah.
But ultimately it comes down to a clinical examination at term. Is this head fixed in the pelvis or not?
Yeah.
Yeah.
And you can, I never liked that test when they used to push on your abdominal area and just to see where that head is. I don't know whether you know, Pat, but that really hurts.
It hurts. Yeah, it does. It does. So important though, because for this patient on this occasion, that was the ball game.
Yeah.
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 It does sound like, in this circumstance you wanted a vaginal birth and you gave it a red hot go.
Yeah.
Yeah. Ultimately not to be. That's okay.
All right. Well, I think we can move on to our next caller.
Hey, Dr. Pat and Brigid, Michelle here. Thank you so much for the podcast and everything you do. I absolutely love it. I recently fell pregnant. First month trying, was so excited. Unfortunately, I had a miscarriage. And I have quite a few questions. I continued to get what I thought was a period bleed all the way through the first 2 months. And to the point that when I tested just before my first period, it was 2 days before my period, I was testing negative and then I got my period. So I was actually a month behind where I thought I was by the time I tested again and was positive. I'm not too sure whether this is related, but also my sonographer pointed out she thinks I might have a septate uterus. Now, it still needs to be confirmed, but I was wondering whether they could be related and also any more information. I know your fascinomas episode, you mentioned septate uterus, but if you could give me any more insight into outcomes, into things like miscarriage, why miscarriage outcomes are so high for women with septate uteruses. Also, when you could be likely to be referred for surgery, do you have to have many miscarriages for that to happen? And then also what pregnancy and birth outcomes kind of look like for women with septate uterus. Any insight you have, I would be so thankful to hear it. Thanks again. Really, really, really appreciate your work.
Thank you for contacting us. I'm sorry to hear about your pregnancy loss. The presence of a potential septum within the uterus could be relevant to the loss of this pregnancy and to your future care. The pattern of bleeding that you experienced around this miscarriage is a little unusual, and we may never have a satisfactory explanation for that. But I think the important thing to focus on here is that if you do have a septum in the uterus, that's where the uterus has got a sort of a wall down the middle. It's thought that pregnancies that implant near or on the septum are much, much more likely to miscarry. And I don't think anyone knows exactly why that is, but it may have something to do with the blood supply in the septum not being as good as the true wall of the uterus. The relevance here is that can be treated, but the first thing we need is a proper diagnosis. So what we get people to have is a non-pregnant expert ultrasound. And this is something that I would tend to refer in Australia to one of these COGIS scanners. They're a subspecialty of obstetrician and gynecologist who are experts with ultrasound. And in particular for a septum, something called a saline infusion hysterosalpingogram is the investigation of choice. So they put a little tube in through the cervix and run some water up into the uterus. And the presence of that water within the uterus outlines the cavity really effectively, and then they can take ultrasound pictures and even create a 3D model of the uterus. And if there's a septum in there that is thought to be of a significant size, then we might have someone who has already had recurrent pregnancy loss or is going to get recurrent pregnancy loss, and that might be worth an operation to cut the septum out.
Mm.
The surgery itself is not major or terribly complicated. It's done hysteroscopically, so that means through the vagina and through the hole in the cervix, and you can usually just cut the septum away. And in expert hands, that's something that could be done as a day case.
Is it a general gynae surgery, or is it someone that's...
Yes, it's done by a gynaecologist, but it's not something that everyone would do. We'd be looking for somebody who had some particular experience with that procedure. And because it's just not such a common thing. So every gynaecologist would not necessarily take that case on, but somebody who'd done several before and was able to cut the septum away. And as you cut the septum away, you can see under vision that the uterine cavity takes on the shape of a normal cavity.
Are people within their rights before they make that appointment with that gynaecologist to ask their reception team, this is potentially my issue, is your gynaecologist? Because, I mean, we don't have that on our website that you can do.
No.
Yeah, so how would they know that a particular gynae can do a particular surgery?
Yeah, I think that's something that should be certainly discussed with whoever made the diagnosis of the septum in the first place.
Yep.
And then say, okay, if this, can I go to somewhere where we're going to be able to trust the result of the scan? And then if it's confirmed, I want to go to somewhere where they have genuine expertise at treating this problem. And it's not rude. You can ask.
Yeah. But can you ask your receptionist before you pay the big, it's not big, but, before you pay the initial consultation and then find out maybe that's not their area of expertise?
Oh, I don't know how patients go asking for that sort of thing. You would probably not get an answer, but you could ask your referring doctor to only refer you to somewhere where you're going to get that expertise, or to ring up and ask themselves, do you do this?
And what's recovery like?
Oh, it's a day case that you would be sort of crampy the next day and fine the day after that. And
then when could you try for another baby?
I think what we would want most people to do is to have at least one period.
Yeah.
And then go for it after that.
Okay.
Small septums, it's not complex surgery to remove them.
Yeah, because some septums are they're not continuing all the way down the uterus, are they? They're just,
Yeah, they just
little nubs.
Yeah, they just come down part of the way.
Yeah.
And it's different to a bicornuate uterus, which has got sort of two separate halves. It's just a line that comes down the middle, and it can be cut away pretty straight in a way that's pretty straightforward.
Yeah.
And then we would just watch that patient very carefully and make sure that they next pregnancy are stuck.
Yeah. All right, Michelle. Good luck with your next pregnancy.
Yeah, all the best.
Our next caller is here.
Hi, Dr. Pat and Brigid. I love the podcast. Thank you for every single episode. I have 2 questions today. One is about retained products of conception. I had a very standard, boring elective cesarean. Everything went well. But 2 weeks postpartum, the bleeding was increasing, not decreasing. And they did a scan and found some retained products of conception, which they removed with a DNC. I'm wondering how this happens in a scheduled Caesar. There was no labour. And from what I was told at the time, everything was removed and everything was intact and there was no complications. So I'm wondering if this is due to surgeon error, or if this is just something that can happen, particularly because it was only a small amount of retained products. I'm just wondering how this happens and if there's anything I need to be aware of for the next pregnancy. And my second question is, some of the retained products were quite adherent and quite stuck. And they wanted to remove what they could gently without doing too much damage to protect my future fertility, diagnosing it as mild placenta accreta. However, none of this was ever diagnosed during the pregnancy, despite very, very in-depth and closely monitored pregnancy with lots of ultrasounds. So I'm wondering if placenta accreta is always diagnosed during pregnancy, or if it can be diagnosed postpartum, and if I should worry about this for my next pregnancy.
Gosh, some of our listeners are so educated, aren't they?
I was just thinking exactly the same thing.
What a perfectly sort of poised question.
It's fantastic.
Yeah, we take all questions, by the way.
We do. You can be poised or unpoised. That was, you've pointed out some. It's an excellent question, pointing out some common issues. Retained products is when a little bit of the placenta or the membranes gets left behind in the uterus after the baby comes out, and typically a few weeks later it can present as an infection or as heavy bleeding. And sometimes the heavy bleeding is happening because there's an infection. And there's just a little bit of devascularized, no blood supply tissue sitting in there, and it becomes a little focus for infection or inflammation. This happens all the time. it's hard to get the uterus 100% empty. And, weirdly, you can have, a vaginal birth and then you put a bit of traction on the placenta and the placenta comes out and you're pretty sure it's not all there. Like a little bit is still there, is still inside. But it's such a little bit that nobody freaks out at the time. We get an ultrasound down the track. It says everything's fine. And then the woman gets a heavy bleeding and the signs of infection and needs a curette. And when you put a curette in there, like a decent piece comes out. And you're like, where's that been hiding? Couldn't see it on the scan and so forth. So, this is tricky. And it's way less common at cesarean section because you've got the uterus open and you can see it. Yeah. Even so, you can't actually see it all. We open the uterus down the bottom near the cervix and once you got the baby out, the uterus clamps down quite dramatically and goes from, your big basketball down to your little apple. And a bit of membrane can hide up the top. So we tend to have a little bit of a look down into the bottom of the uterus, just south of the cut, around about the top of the cervix, and mop down there and make sure that there's no membranes down there. And then we tend to get an instrument called a swab on a stick, which is a clamp with a cloth on the end, and put it up towards the top of the uterus, up where the tubes come off. And mop around up there as well. But it's not true that you can see the whole inside at a Caesar. If we open the uterus enough to see the whole inside, then it'd be very hard to put it back together again. Yeah. So
you don't want that either because that, would cause other problems.
Way more problems than it solved, yeah. So you can get retained products at a section. And it doesn't mean they didn't look, it's just that it didn't go entirely according to plan.
Yeah.
So what happens, you do a curette if ultrasound shows that there's a volume of retained products that's worth curetting out. It should be done under ultrasound guidance because the Caesar scar is still new. So you don't want to just poke a curette blindly up the uterus under an anaesthetic because you might actually poke a hole in the Caesar scar.
Yeah, wow.
So you do it under ultrasound guidance to make sure you get past the Caesar scar up into the upper bit and grab the retained products you're looking for. And that has to be done gently because postpartum curettes are thought to be one of the more important causes of Asherman syndrome. And Asherman syndrome is where we cause some inflammation in the lining of the uterus that causes the front to get stuck to the back and obliterate part of the cavity. And that can be a cause of secondary infertility. So if somebody has got the bit of retained products followed by some infection, followed by all the associated inflammation, and then we go in too hard with the curette and scrape, then it can cause the front of the cavity to get stuck to the back of the cavity.
And how would anyone know? They don't know at the time. Do they then find out if they've got Asherman's if they try for a pregnancy later down the track?
In the textbok case, it's they can't get pregnant again. Yeah, and eventually we go looking in with a telescope and you find that internally the front is stuck to the back and there's an operation you can do to undo it, but it's much nicer not to cause it in the first place.
Yeah.
So the curette's done for retained products after Caesar, should be done under ultrasound guidance and gently. And if this person says that there was a diagnosis of mild accrete. Oh, yeah, that's interesting. So if the little bits of retained products up in the uterus, perhaps a tiny bit of placenta, perhaps a bit of membranes, if it's just stuck there, it might be stuck there just because it was just a little bit stuck, or it's stuck there because of the subsequent infection that happened. That's one thing. But sometimes you send the products to pathology and they can very accurately see down their microscope. They're very clever. They can see that mixed in with the retained product are fibres of the uterine muscle.
Yeah, right.
And that means that there was an abnormal connection between the placenta and the uterine muscle. And that's placenta accrete. But only that little bit of the placenta that got left behind was an accrete. The rest wasn't attached.
Yeah.
And it's a bit hard to know exactly what to do about that because the other part of the caller's question was, if there was a bit of accrete, why didn't they find it? Well, I think we can agree that if there was accrete, it was only that little bit that was left behind. The rest of it was fine. So the scan probably looked normal. And multiple scans probably looked normal. And even in the bad accretas where the whole placenta is stuck, lots of those look normal as well.
Wow.
So most accretas are a surprise. Still,
yeah,
there are some ultrasound signs of accrete, but they're not always detected. MRI is probably a better test, and someone who we think is a sitting duck for an accretor, like someone with 3 or 4 previous Caesars, and then they get an anterior placenta previa where the placenta previa is over the 3 or 4 previous caesarean section scars. We know that person's got a very high risk of accretor, so we send those people off for an MRI, and they'll say, oh, yes, definitely, you can see there's an abnormal connection, or they say, no, it looks fine. But ultimately, you need to be prepared for that outcome at the birth, because neither ultrasound nor MRI are 100% on this.
And once you have a placenta accretor, is it likely that your subsequent babies will have a placenta accretor?
Well, just put you at higher risk statistically.
Yeah.
So, for example, if this woman has more babies, which presumably would be born by caesarean section because this one was, although we don't know the exact circumstances, but let's say they were, then the team setting out to do those subsequent sections would be wise to know that whole story.
Yeah.
And be prepared for a potentially adherent placenta.
Pat, I wanted to just pick up on something that you said right at the start when you said this happens all the time.
Retained products is common, and despite our best efforts, it happens.
All right, let's move on to our next caller.
Hi, Dr. Pat and Brigid. My question is around second labours or births. I've always been told that your second labour or subsequent labours are generally quicker and your body tends to know what to do the next time around. For a bit of context, I am just over 2 weeks postpartum and my birth did not go to plan at all, and everything that could have gone wrong went wrong. So I pushed for 2.5 hours and ended up with an emergency C-section. My question, I guess, is if my body managed to get to 10 centimetres but I didn't deliver vaginally, is it still the case that my body will know what to do next time or not? Thank you so much for the podcast. I've listened to it the whole way through my pregnancy, and it was really, really helpful. Thank you.
The old 10 centimetre emergency caesarean.
Yeah, Caesar at full dilatation is a tough one. Sorry it didn't go according to plan, and I hope you're adjusting well to that. The Caesar at full dilatation, it suits nobody. The poor patient has had all of the hassle of getting to full dilatation and then potentially disappointment in needing a section. And the treatment team don't want to do a Caesar at full dilatation. It's hard. Sometimes their head's a long way down. Sometimes it might happen as a result of a failed instrumental delivery where the head is super long way down but can't quite get it out and got to use various techniques to push it back up.
Yeah.
So it's hard, and it's commonly followed by postpartum hemorrhage. So, this is a tricky day for everybody. To answer your specific question, somebody who's had your history when they get pregnant again, they'll typically labour like somebody's had a previous vaginal birth because they've dilated before. And so they do get the benefit of a labour that's more efficient and typically faster. But once you get to full dilatation, because there's been no stretching of the vaginal tissue before because the baby didn't come out vaginally, from that point on, they're going to behave like someone who's had no previous. More like someone having their first vaginal birth. And so this doesn't mean that you can't have another that you can't try an attempt at a vaginal birth after a previous Caesar. But, that's where it gets tricky.
But maybe if she's had, this is all theoretical, hypothetical, maybe if she's had a quicker, more efficient labour, she might have more in the tank. More in the tank in the pushing phase.
I definitely think that's a thing, and more efficient pushing because you got from 0 to 10 faster. Then slightly smaller head, slightly better fit, different day.
Yeah.
It might go perfectly.
Yeah.
Because we don't know and can't predict. This is why if someone has a vaginal birth with a previous section, that should be done under expert supervision in a hospital. But it's a good idea to give it a try if you meet the criteria.
Yeah. Yeah. And maybe even if you did have a great labour in the second birth, but it looked like it was going down the path of needing another caesarean, maybe they'll call it earlier.
Yes, that would
get to full dilatation and have that sort of a situation.
Well, very good point. I mean, that's why the progress required to be having a healthy vaginal birth with a previous section, we're more concerned with progress for those patients than someone with no previous sections.
Yeah.
Because the ones that take too long, are at higher risk of uterine rupture, and maybe that should have been called off before you got to fully dilated if the progress was poor.
Good luck with your next birth. We hope that it goes very well for you.
I hope that goes super well.
Super well. We need all those ducks in a row, don't we?
Yeah, there's a lot of ducks in a row for safe feedback.
Yeah. All right, Pat, I think we've got time for one more. Gosh, that's gone fast. And it's another second birth question. So
good.
Yeah, that person
it's been our theme.
It has been our theme for this one.
Hi, Dr. Pat and Brigid. My name is Hillary, and I'm calling from the United States. I'm currently 15 weeks pregnant with my second baby, and I've been enjoying your podcast, particularly episodes 34 and 114 on VBACs. I gave birth to my first baby 3 years ago by C-section. The pregnancy was uncomplicated, but the baby was breech, so a C-section was indicated. My question is regarding expectations for this birth, as I'm hoping for a VBAC. So for a VBAC with a second baby, should the mother expect to have a longer labor and potentially more tearing, as many mothers experience with their first birth? Or should I prepare for a shorter labor and birth, as this is my second child, regardless of the facts that the first birth was a C-section? Thank you so much, and I'm looking forward to hearing your thoughts.
You know, we've had the question about I got to full dilatation. Now this is someone that hasn't laboured at all.
Yeah.
Yeah.
We're assuming that the breech was known about in advance.
Yeah.
And that the first baby came as a Caesar without labour.
Yeah.
Yeah. It wasn't picked up during the labour.
No. I feel like that was the question.
Yeah. So this is relatively easy in that if
easy answer, not an easy
not an easy situation, a relatively easy answer.
Yeah.
A woman in this situation is very likely to labour like someone having their first baby, and that's because they haven't laboured before. And as far as the process of labour is concerned, it is their first labour. The question about success of VBAC is an interesting one, because when the Caesar is done for a known complication of pregnancy and the woman has not laboured, so for example it was done for twins, placenta previa or breech, that would be the most common, then for all we know, that woman labours fine and she may be an excellent VBAC candidate. Whereas somebody whose Caesar was done for an in-labour problem like a very poor progress or, a petite woman having a 4-kilo baby, to a certain degree we can make a guesstimate that might happen again and that might affect that woman's suitability for VBAC or her chance of success. But I always say to people who haven't laboured at all, for all we know, you're the perfect candidate. And within the normal safety assessment, check out the second pregnancy. How's it going? Do we fit the criteria in a hospital under expert surveillance? These are often the ones that we expect to go very well.
So it just sort of highlights that it's best for that person to prepare for both. Do all the information that you would need if you were going through to a vaginal birth and get all the information if you need to have a cesarean or even assisted. Like you need to know the whole realm of birth, don't you?
That's right, especially because our preparation for VBAC is about hoping for the best but preparing for the worst. Then we don't know how it's going to go. So I think people in this situation, they need to know about vaginal births and tearing and so forth. They also need to know a bit about cesarean sections. They've had one, they might need another. And they also need to know about VBAC. What are the rules? What is your carer looking at?
Yeah, because that differs from carer to carer, doesn't it?
It really does.
Yeah.
And I think knowing a little bit of something about that is very wise. So what are the criteria in which I'm considered to be a good candidate? And then what sort of progress do I need to be making in labour to remain a good candidate?
Yeah, exactly. And what things change in a pregnancy that would make me no longer a good candidate?
Exactly, yeah.
All right, that's it for today. I want to say if anyone is wanting to be super prepared for their birth and have questions during their pregnancy, then I highly recommend you come and join our Grow My Baby program. I'll put the link in the show notes, as it always is. Pat and I have priced it accordingly so you can have access to it. Anyone can have access to it. So we highly recommend that you come into that program, get week by week information that really helps you have an empowered informed birth. And that's what we want for everybody.
I think you'll really enjoy it.
All right, everyone. Hope you got your question answered in the Q&A. If not, come again on the website. growmybaby.com.au is the SpeakPipe link. Pop your question in there and we'll see if we answer it.
We'll see you all next week.
Bye for now.